Vanakkam. When we get a patient with a fracture of a hand bone, first we need to understand what are the basic steps needed to treat this patient. And when we go into that, we will find that there are multiple modalities available. You can apply a POP, you can apply an external fixator, you can put in screws, you can put in a plate and screws. There are so many methods of management. That is going to be a little confusing because we need to decide what is to be done for that particular patient. To help us decide, they are going to learn about the principles of each and every type of management technique. For instance, if it is going to be splinting, which are the patients in which we can apply a POP? If you are going to talk about external fixators, how are the fixators applied? What are the different types of fixators applied with reference to fractures on the hand bones? And if it is going to be plate and screws, what is the type of plate and screw that is going to be applied and how should it be applied? All this and more in this video on principles of management of hand fractures. The goals of management of any fracture are to obtain fracture union in the most anatomical position compatible with maximal functional return and minimal soft tissue and bone injury. And to achieve this, there are 4 steps to be followed. Diagnose correctly, reduce the fracture, maintain the fracture in the reduced position, and rehabilitation. Since the step of diagnosing the fracture has already been dealt in a different video, we shall dwell on the 3 other steps: reduction of the fracture, maintenance of reduction, and rehabilitation. Reduction of the fracture refers to bringing the fracture ends to anatomical alignment, and this must be done to maintain function, that is, to prevent functional impairment or a short limb, to avoid soft tissue scarring in the callus, and to prevent abnormal loading leading to osteoarthritis. It will also help to start mobilization predictably, to ensure the vascularity, and to prevent neurovascular compromise. Correct anatomical reduction of the fracture also helps to give cosmesis to the functional part. The various techniques by which this reduction of the fractured ends can be done are manipulation under anesthesia, traction, open reduction, and closed reduction and fixation. After reducing the fractured ends, it is important to keep the reduced fracture ends in alignment, because though the reduced position will bring the fracture ends into alignment, it cannot be maintained due to the forces that are constantly acting on the bone. So the reduced fracture ends must be maintained to ensure healing. This can be achieved by closed methods, open methods, external stabilization, or internal stabilization. The closed method with external stability can be provided with the POP slab or splints. The open method providing external stability can be with the help of external fixation. Closed methods with internal stability can be achieved by techniques like percutaneous wiring of the fracture, and an example of open method providing internal stability is the maintenance of the reduced fracture ends with plate and screw fixation. Now we know that maintaining the reduced fracture will get a good healing, but there are 2 types of healing as we have already seen, and the different treatment protocols will give either secondary healing or primary healing. We need to understand which treatment protocol provides which type of healing. Basically, we know we have 2 types of methods: closed reduction and open reduction. The methods of external immobilization, like using cast, splint, traction splint, or fracture brace; closed reduction with external fixation, or closed reduction with internal fixation with techniques like percutaneous pins, percutaneous K-wires or external fixators; or coaptive fixation with techniques like K-wires, intraosseous wiring, intramedullary pins or nail, will result in secondary healing of the fracture, whereas stable fixation techniques like interfragmentary screw, tension band wiring or tension band plating, and rigid fixation techniques like the use of lag screws, or plate and screws will result in primary bone healing. So these are the techniques that result in secondary healing of the bone, and these are the techniques that result in primary healing. So let us summarize this in terms of stability that is provided by the treatment protocol, which could be absolute stability or relative stability. Absolute stability would be provided by techniques like lag screw fixation, axial compression with compression plate, buttress plating, or tension band wiring. And relative stability, which is characterized by relative motion between the fracture ends, which can occur with extramedullary or intramedullary splinting, is characterized by callus formation, though the length, alignment and rotation are maintained. So now we have seen the different methods of maintaining reduced fractures and obtaining different types of healing. It is not enough to just treat the fracture per se, but it is very important also to rehabilitate and get back function. Initiating movements is very important, and it should be attempted as early as possible without jeopardizing maintenance of reduction. This is because stress is needed for the final stage of fracture healing, which is remodeling. It is not only the fractured part that we need to concentrate on during rehabilitation, but also move the unaffected areas. Though we have learnt the 4 basic steps of fracture management, we have noted that maintenance of the reduction consists of so many techniques. And what is important now is to learn the principles of these techniques. That means we shall be learning about the principles of external splinting, principles of external fixation, and principles of internal fixation, including the use of K-wires, lag screws, and plates and screws. First, let us consider the principles of external splinting. We need to understand that almost 90% of hand fractures are appropriately treated without surgery with simple closed reduction techniques, appropriate splinting, and early protected mobilization. And at the same time, the complication rates of operative treatments can be as high as 36% for metacarpal fractures and 50% for phalangeal fractures. So that makes it all the more important to understand how external splinting is used in the management of hand fractures. External splinting helps to immobilize the fracture ends and promote secondary healing, provides pain relief, reduces further damage to the neurovascular bundles, and reduces the chance of converting the simple fracture into a compound fracture or open fracture. The obvious advantages of external splints are that they are cheap and easily available, they are versatile, can be very readily applied, they are strong, radiolucent, and we have different choices of material to be used like POP and fiberglass. However, there are some disadvantages too. They are not waterproof, they can be heavy and warm, we cannot inspect the wound without taking them out completely, and they may also cause pressure problems over bony prominences. The different modalities of external splinting available are traction, splints, and braces. First, let us consider traction as a modality of reducing fractures and maintaining them in the reduced position. It essentially refers to the process of pulling the bone ends directly or indirectly to reduce or maintain the reduction. This can be achieved by skin traction, skeletal traction, gallows traction, or in the case of hand fractures, nail traction. This nail traction is sometimes known as long aluminum splint traction, LAST. It consists of 5 steps. The first step is wrist stabilization with the POP slab, which is applied up to the distal palmar crease. The next is incorporation of a long aluminum splint into this POP slab, then application of a suture to the nail plate of the involved finger, after which traction is applied to the nail and the finger to mold the fracture, and finally attachment of the suture to the aluminum splint to maintain the fractured ends in reduced position. This shows the POP application and the incorporation of the long aluminum splint, application of a suture to the nail and providing traction, and the final construct. The use of this technique is ideal for basal fractures of the proximal phalanx, which are either difficult to approach or difficult to fix. In these cases, satisfactory alignment can be achieved by this technique, and the metacarpophalangeal joint position is also maintained in flexion. Next, we shall consider the use of splints. Splints are devices to maintain the reduced fractures in desirable position. So the ideal position of splinting would be one that best resists fracture displacement and soft tissue shortening with subsequent stiffness. And this ideal position would be 20 to 30 degrees of extension of the wrist, 70 to 90 degrees of flexion at the metacarpophalangeal joints of the fingers, and full extension of the interphalangeal joints. There are three types of splints that can be used for hand fractures: the volar splint, the dorsal splint, and the thumb splint. Splints can be in two forms, either in the form of a slab or in the form of a cast. A slab is indicated for acute and definitive treatment of select fractures, for management of soft tissue injuries like sprains or even tendon injuries, or in the acute management of injuries awaiting orthopedic intervention. The advantages of using a slab are: it allows for acute swelling, decreased risk of complications, and a faster and easier application. And the disadvantages of using a slab are lack of compliance, increased range of motion at the injury site. This is because there is a splint only on one side and the other side is only covered with bandage, and it is not useful for definitive care of unstable or potentially unstable fractures. The complications of slab application could be skin breakdown, joint stiffness and muscle atrophy if applied for too long, and deformity if it has been incorrectly applied. The advantage of cast application is more effective immobilization, but the disadvantages are a higher risk of complications and a little more technically difficult to apply. Application of this splint consists of 5 steps. First, application of gauze between fingers, then a gauze roll or a soft roll, a bandage, application of the slab, and again a bandaging. The padding that we apply during the application of the POP splint must be as thin as possible to achieve a good reduction and molding of the fracture. The cast or slab could also be applied with fiberglass. They are lightweight, waterproof, but set very quickly. Finally, a word about the use of braces as external splinting. These braces prevent joint stiffness while still permitting fracture splintage and loading. They are not very rigid, so they are usually applied only when the fracture is beginning to unite. Next, we shall consider the use of external fixators. As far as hand fractures are concerned, we will be using two types of external fixators: static and dynamic. The indications for the use of external fixators are for stabilization of severe open fractures, initial stabilization of soft tissues or bone in polytrauma, management of closed fracture with associated severe soft tissue injuries, infected fractures where internal fixation might not be suitable, in severely comminuted and unstable fractures, or fractures with small intra-articular segments which are difficult to fix. The advantages of using external fixators are that there is minimal loss of blood during installation, simple and easy application which can be adjusted with ease after the surgery, and it also provides easy access to manage and care for the wounds and sometimes even provide the skin cover. The disadvantages of external fixators are the complications that can occur, which could be either mechanical, like destruction of the fracture site, inadequate immobilization, and the weight or the bulk of the fixator as such, or biological problems like pin tract infection, neurovascular injury, or tethering of muscles. The basic modular external fixator consists of two partial frames A and B, one on each main fracture fragment. Each partial frame consists of two pins in a bone fragment connected with a rod. The two partial frames A and B are joined with a rod-to-rod construction or connecting rod C. To construct an optimal frame, the pins must be placed near the fracture site but not too close, and the pins must be placed widely separated within each main fracture fragment. If we want to make the frame stronger, we can use thicker pins or position the connecting rod closer to the bone or add a second connecting rod, otherwise known as a neutralization rod, or we can add more pins in each segment. The external fixation that we have done can be used as a temporary fixation in some situations. If it was used because the patient was not fit for the internal fixation procedure, the definitive procedure can be done when the condition improves and the external fixator can be removed. If it has been used because of extensive soft tissue damage, if the soft tissue injuries are healed in 2 weeks and there is no pin tract infection, the external fixator can be removed and internal fixation can be done. If there is pin tract infection, we need to remove the external fixator, debride the pin sites, stabilize with a POP or slab, or apply another external fixator in new pin sites. The external fixation that we apply can also be used as a definitive fixation in certain situations. In the event that a soft tissue healing is not satisfactory even after 4 to 6 weeks and there is no pin tract infection, the external fixator can be left on until the fracture is healed. In non-compliant patients, the external fixator is the first and final treatment. And in children, fracture healing is often complete by 6 to 8 weeks. If external fixation is initially chosen, it should remain until complete fracture healing. In the hand, there are situations where though we apply an external fixator, we need to maintain the function of the joint. In such situations, articulated external fixators can be applied in conditions of intra and periarticular fractures or ligamentous injury. An example is the Suzuki frame, which allows joint motion even while keeping the fractured fragments in reduced position. Now let us consider the principles of internal fixation. The indications for internal fixation are either relative or absolute. The situations where we must do an internal fixation are when we are unable to obtain an adequate or stable reduction, when there are displaced intra-articular fractures, in certain types of displaced epiphyseal fractures, in major avulsion fractures where there is a loss of function of a joint or muscle group, and also in replantation of limbs or extremities. There are some situations where we can do an internal fixation, like in delayed unions, in patients with multiple fractures so that it would be easy to assist in care and general management, in pathological fractures, in situations where it is necessary to reduce the morbidity due to prolonged immobilization, and finally, it can also be done for fractures in which closed methods are known to be ineffective. Apart from joint stiffness, the complications that can occur from internal fixation are infection and non-union, which could occur due to excessive stripping of the soft tissues, unnecessary damage to the blood supply, and the application of a rigid fixation with a gap between the fragments. The advantages of internal fixation are earlier functional recovery, more predictable fracture alignment, and potentially faster time to healing. Some examples of the methods of internal fixation available are K-wire fixation, which is an example of coaptive fixation, screw fixation, which is an example of stable fixation, and plate and screw fixation, which is an example of rigid fixation. As the fixation method goes from coaptive fixation to rigid fixation, it becomes more and more stable. The simplest method of internal fixation of fractures of the hand is by use of K-wires or Kirschner wires which have a diameter of 0.6 to 3 millimeters. If they are more than 3 millimeters, they are known as Steinmann pins. K-wires can be fully threaded or non-threaded, and they can have diamond or trocar points. K-wires can be used as definitive fixation or a provisional fixation. K-wires can be used in the fixation of hand fractures in the epiphyseal or metaphyseal areas of the phalanges and metacarpals. They can also be used for small bony fragments as in fracture of the ulnar styloid or radial styloid, and for fracture repositioning in multi-fragmentary fractures in addition to stable fixation, like for instance in Bennett fracture or the Rolando fractures. We need to remember that K-wire fixation alone does not provide sufficient stability. That is why it is called coaptive fixation. Why is it unstable? Is because of the axial instability. To avoid this, a double fixation needs to be done, which could be by the use of cross K wires or the use of an additional stainless steel wire or external support with a POP slab. Another important point to remember when using K wires for fixation of fractures in the hand is to avoid fixing important joints. In the case of metacarpal fractures, we need to avoid fixing the metacarpophalangeal joint, and in the case of phalangeal fractures, we should avoid fixing the proximal interphalangeal joint. The advantages of using the K-wire as a method of internal fixation of hand fractures is that it is cheap, universally available, can be inserted with a hand drill, either manual or pneumatic, and it is easy to remove. The disadvantage of the use of the K-wire, as we have already seen, is that it is not functionally stable. The size of the K-wire to be selected and used for fixation of the fracture depend on the patient's age and weight, the fracture location, the fragment size, and the K-wire trajectory. We shall discuss the details of these when we talk about the individual fracture management. Another important thing to remember when using K-wires is to avoid thermal injury. When using a manual hand drill or an oscillating drill, the rise in temperature in the cortex is not much. But if a standard drill is used, it needs to be used as slow as possible with continuous irrigation using cooled saline. The next important method of internal fixation is the use of lag screws. Screws are of mainly three varieties. The cancellous screw, which has a larger thread to core diameter ratio, the pitch is greater and theoretically allows better fixation in cancellous bone. The cortical screw, which has a greater number of threads, a smaller pitch, which has a better hold in cortical bone, and the screws can be solid or cannulated. Depending on the way in which they are used, screws can be positional screws, plate screws, blocking screws, or lag screws. And in management of fractures of hand bones, the lag screws play a big role. When a screw compresses both sides of the fracture together, it is the best form of compression which has poor shear, bending, and rotational force resistance. Such effect of compression can be achieved by lag screws, which can be a partially threaded screw where it is called lag by design, or a fully threaded screw where it is called a lag by technique. First, let us consider the lag screw by design. By design, it is a partially threaded screw so that this screw threads into the far cortex and the smooth shaft slides in the near cortex. So as it is tightened, it compresses the two segments together. It is used to compress fractures in cancellous bone. When we consider the lag screw by technique, the screw as such is a fully threaded screw which can achieve compression by using a very different technique. This technique consists of first creating a glide hole in the near cortex. That is, the cortex under the screw head is drilled to the size of the thread diameter so that the thread gets no purchase. So this is a much wider hole. Next, the thread hole is made. It is a drill hole which is the same diameter as the core of the screw, and a tap is used to cut the spiral groove that receives the thread of the screw. This is a narrower hole. So when the screw is inserted and tightened, it causes compression because only the far end is engaged in the bone. The commonest applications of lag screws in the hand are for the fixation of long oblique fractures of the metacarpals, where a minimum of 2 screws need to be used. It is important that the length of the fracture be at least twice the diameter of the metacarpal bone. If the fracture is shorter, a single lag screw and a protection plate need to be used. Lag screws should be inserted perpendicular to the fracture plane. If this is not done, displacement of the fracture ends occurs with compression. When multiple lag screws are used for long oblique or spiral fractures, the result is that the screws follow a helical disposition. One other type of screw that can be used in hand fractures, apart from the headless screw that can be used for scaphoid fractures, are the intramedullary cannulated headless compression screws, which can be used for fixation of metacarpal fractures or phalangeal fractures. Now we shall see the role of plate and screws in internal fixation of fractures of the hand. A plate may be positioned to provide one of the following types of structural support: either neutralization mode, buttress plating, bridge plating, tension band plating, or compression plating. Let us see what these mean. When a plate is used in neutralization mode, it means a lag screw is used to neutralize the bending, shear, and rotational forces, and the addition of a plate provides further resistance to such forces. Here, the plate is in a neutralization mode and it's typically used in short oblique fractures of the metacarpals. It is sometimes called a protection plate. A buttress plate is used to prevent a collapse in fracture patterns which are unstable under compressive forces. Hence, they are applied on the compressive surface of the bone and typically used in fractures like the lower end of the radius. A bridge plate is applied when there is a comminuted segment of fracture. It minimizes the devitalization of the fracture zone and also promotes the formation of a periosteal callus. In tension band plating, a plate can also be solely used as a tension band apparatus. Here, the plate is attached to the tension side of the fracture and it is based on the principle of tension band, that is, it converts the tensile force into a compressive force. An example is the tension band plating of the olecranon fracture. This effect can also be achieved by wiring, which is known as tension band wiring, by use of K-wires and stainless steel wire based on the same principle. Example, fixation of fractures of metacarpals. Finally, the compression mode. When the plate brings the two fragments closer to each other so that the fragments oppose well, the plate is said to be in compression mode. It is typically used for fixation of transverse and oblique fractures in the hand. When a plate is used in this compression mode, it allows for anatomical reduction, early active motion, and shorter rehabilitation period. This compression can be achieved by two important techniques. The first is pre-contouring, where we overbend the plate so that it stands 1 to 2 millimeters off from the anatomically reduced fracture surface. The second is the insertion of the screw in compression mode in the opposite fragment. Here, the screw hole is eccentrically shaped. So as the screw is tightened, it slips downward and compresses the two fracture fragments. The plate sizes that are used for hand fracture fixation are 1.3, 1.5 2.0 and 2.4 mm. The plate shapes that can be used for hand fractures fixation are Y, T, H as well as the regular straight plates. We also need to remember that the plate span ratio for comminuted fractures is 3 and for simple fractures is 8. Here the plate span ratio refers to the ratio of the plate length to the fracture length. This means that a simple fracture needs a longer plate than a comminuted fracture.
I hope you enjoyed this video. I enjoyed making it. Please do click on the shown links to see more about the basics of fracture management, that is, fracture healing and the anatomy of the bone. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery and trauma surgery. Vanakkam.